It's the world's deadliest infectious disease after HIV/AIDS. But the fight against tuberculosis is being dealt a double blow. A new study says developing countries are awash with fake and substandard drugs. That's making the disease more resistant and in some cases virtually impossible to treat. Hello there and welcome to the programme. I'm Laura Kyle. Virulent new forms of tuberculosis, or TB, are threatening to wipe out a decade of gains made in the treatment of the disease. Substandard and counterfeit antibiotics are contributing to dangerous new strains that are resistant to some or all of the drugs on the market. Investigators in the United States are reporting alarming findings from the biggest ever study of its kind. Researchers collected samples from 2 frontline antibiotics used to treat TB from pharmacies and local markets in 17 countries. They found nearly 1 in 10 failed to meet basic quality standards, and around half of those that failed had no active ingredients at all. Most of these substandard drugs came from legitimate manufacturers, but had been poorly made or had corroded in transport. Others appeared genuine, but turned out to be fake. And it's this misuse, mishandling and mistreatment that's conspiring to make TB more resistant. OK, well, let's cross over now to our guests. In our Washington studio, we have Paul Jensen, co-author of that study, Substandard and Falsified Anti-Tuberculosis Drugs. In Kiev, Masoud Dara from the World Health Organization's Tuberculosis Programme. And in Geneva, Lucica Ditiu, Executive Secretary of the Stop TB Partnership. Thank you all very much for being here. Paul Jensen, if I could start with you. I mean, some astonishing figures here. 1 in 10 TB drugs failing to meet the basic quality standards. Were you surprised to find such a high number?
We weren't that surprised, actually. I mean, when you go to these countries, it's very easy to buy drugs over the counter. It's easy to buy drugs from people on the side of the street in a lot of places. Any pharmacy you go to, I was in India a few months ago, you step into a pharmacy and you can buy these drugs off the shelf. The exact data, the numbers, they were high and they were startling, but we weren't entirely surprised by what we found.
How exactly are these drugs substandard?
So the test that we did was a chromatography test, which just means that we looked for the chemical makeup of the pills. And we looked for how much active pharmaceutical ingredient was in those pills. That's the molecule, in the case of a TB drug, that actually works against the TB germ, to kill the TB germ. And we looked to see how many pills met the level of required amount of active pharmaceutical ingredient versus those that didn't. And if they were below 80% of the required level, we counted those as substandard.
Lucica Ditiu, over there in Geneva, if these frontline antibiotics to fight against TB are fake, I mean, presumably the worst that happens is that the patient dies. But if they're substandard, what is the impact that this has on fighting TB?
Obviously, this has a huge impact, as it was also allured before, and in all these articles that came and will come. Because basically what we give then to a patient, it's actually you don't give them the right treatment. So in addition to the fact that the patient remains infectious and his treatment results will be really, really poor, you also develop a multi-drug resistant TB, which is one of the worst forms of TB that unfortunately we have in this world. And that's much more difficult to treat, it's much more difficult to cure, and it's much more expensive. Then if you have an MDR-TB patient who takes as well counterfeit drugs or drugs of very poor quality, you are then going forward and you develop XDR-TB, which is a more advanced form of a resistance. So the fact that countries unfortunately are procuring so bad quality of drugs, it's something that we are very grateful for in the partnership for the study coming out and for showing it so clear. And it requests an additional push from us all. We, in the Stop TB partnership, we have a structure which is called Global Drug Facility that is providing quality assured drugs, first-line drugs and second-line drugs to the countries, either through grants, either through direct procurements. And that's one way to go forward. But beyond that, another way to go forward is to really work with the countries and ensure that they are trying and doing their best to buy quality assured drugs, and also that if they are manufacturers, that they are respecting the international rules in terms of assuring the proper quality.
And we'll certainly revisit more ways to try and address this problem a little later in the programme. Masoud Dara, I want to bring you in there from Kiev. Just to outline for us how much of a problem is this rise in multi-drug resistance forms of TB?
Yes, actually the problem of multi-drug resistant TB is a major issue for the TB control overall, but also is a general health system problem. Is that also is a mixture of different issues relating to also the health systems not being adaptable to the patient's needs. As you know, the treatment is quite long, 6 to 8 months, and many patients stop treatment because as soon as they feel good, or they go for over-counter treatment, self-treatment. As a result, the Mycobacterium tuberculosis can become resistant to the drugs, and then what we have now is a MDRT or multi-drug resistant tuberculosis. In fact, we have estimated about 500,000 multi-drug resistant tuberculosis occurring around in the globe. And unfortunately, many countries in Europe are suffering from it, particularly in Eastern Europe, where for many years there were some ruptures in the health system structure after fall of the former Soviet Union, and as well as some of the issues like the airborne infection control, which were not following intensively. For example, healthcare facilities have been also a center where the tuberculosis, multi-drug resistant tuberculosis, can be transmitted from one patient to another. In fact, in Europe, about 70,000 multi-drug resistant tuberculosis patients occurring every year, which that's the reason the WHO, World Health Organization, works intensively with all the member states to develop an action plan to control and prevent multi-drug resistant tuberculosis.
OK, so we've established there from all three guests that this is a huge issue. Let's just use this moment to identify what exactly tuberculosis is and the full scope of its effects. Well, it usually impacts the lungs and is spread from person to person by coughing and sneezing. Around 9 million people falling ill from TB every year, and of those, more than 400,000 have a form of the disease that, as we've talked about, is considered multi-drug resistant. Now, in 2011, 1.4 million people died from TB, although that figure has been falling since 2006. Lucica Ditiu, it really does sound like a particularly nasty disease. Talk us through it. Explain to us what it is exactly that people die from.
When you die of TB, the disease advanced very much into your lungs and is producing a destruction. And for those of us looking at the cinema, there is this movie that is now coming out, Les Miserables. And unfortunately, even though we know tuberculosis for the last 2,000 years, people are dying with TB, and in this world, in these huge numbers that you just said, actually we have 3 people that are dying with tuberculosis every single minute. Having symptoms very similar with what we see in these movies or what we read in these books. There is, hemoptysia, and then, the body is extremely weak. So it is a tragedy, and the tragedy is becoming even bigger because we are having now these forms of more resistant tuberculosis that are creating additional burden for a patient. So in addition to the fact that you have to fight with the disease itself, you have to fight with a lot of side effects that are given by the drugs in order to treat this form of drug-resistant TB, which are extremely difficult to manage. And considering the fact that the treatment of tuberculosis in case of drug-resistant TB, that is something that we are extremely concerned about, and I think also here we mentioned it several times, as Masoud mentioned already, is a 2 years long treatment. And if you put to this the symptoms that are over there, which are huge nausea and vomiting, and as well a lot of psychological symptoms, we realize what a burden this is.
Enough problems there taking the medication, let alone throwing in substandard versions of it. Paul Jensen, in this report it was said that a lot of these substandard pills came from legitimate manufacturers. How can that be?
Mm-hmm. Well, I mean, there are two basic types of substandard drugs that we're looking at. One is manufacturers making good drugs that have then gone into the supply chain and have degraded because they haven't been stored properly by the time that they reach the patient. They've broken down at some point within that chain. Others are otherwise good manufacturers that sometimes make substandard products, and I don't want to speculate for individual cases, but there are any number of steps along the production process that, if are not maintained at a high quality, can lead to a substandard product.
Masoud Dara, where ultimately does the responsibility lie to stop these substandard medications reaching people who think they're doing them good?
Yeah, it is a joint responsibility of the member states, ministers of health, but also civil society organizations, patients themselves, families, communities, and everyone. TB is not only a clinical problem, it's also a social problem where part of the society, particularly those who are less privileged, because of poor housing, poor nutrition, they're mostly affected. Having said that, TB, tuberculosis can affect everyone and anyone. That's the reason we emphasize that all the ministers of health need to work further to provide access to treatment for all the patients in all parts of the societies and communities, and also linked to poverty and also other social issues that needs to be addressed, including housing, nutrition, improving care for all the patients. On the other hand, also another most important issue is also need for new drugs, new medicines, and new research for TB drugs and vaccine. That's what we need to more have a better further work on that one. New diagnostic tests has become available, endorsed by WHO. This is a revolutionary by molecular techniques. This is a very good news that we can diagnose TB soon. But this new technique have not been reached the places it should go right now. So a lot of work needs to be done. A lot of resources need to be given to brought this under control. Otherwise, we'll have to spend much more on TB control in the future. We made a calculation. Every $1 spent on TB control can save you $10 in the next 3 years. This has actually been scientifically proven.
Absolutely. More research needed. Unfortunately, we've documented another setback in the fight against TB. Scientists had high hopes for a promising new vaccine, which would have been the first in almost a century. Now, the trials did go well in adults, but it had, unfortunately, very little impact on babies. Researchers in South Africa selected 2,794 healthy babies who'd been given the standard BCG vaccine. The new vaccine was then given to around half of them and a harmless control drug given to the others. That was all part of a 3-year trial. Now, 39 cases of TB were found in the control group and 32 cases in the group who had had the new vaccine. So no significant distinction and certainly not the breakthrough that was hoped for. Luchika Ditu, why is it proving so difficult to produce a vaccine?
We in many occasions we call TB kind of the orphan disease, and as you rightly said, we had the BCG, which is exactly 100 years old, and then we had no work whatsoever on a vaccine for TB. This is the first time, and I know that disappointment is the word that was used a lot yesterday in all the press and everything, but I think we have to realize two things. First, this is the first time that we try a new vaccine in 100 years. And like in any research, you can have very good results. You can have as well results that are less good, but still help us in learning a lot. And by doing all the trials and all the studies for so long time for the colleagues that were involved in it, it provides a huge amount of information that will be serving for the development of the vaccines that are in the pipeline. Because let's make clear two things. One is that this is not like we had one, we put it all the hopes in this one, and now that these results are not as good as we hoped, we are done. There are many others in the pipeline to come and to go into the different trials and then different studies, part of the studies. So I'm pretty sure that, all the other groups working on the vaccines development are now on a higher speed, and they learn from what was obtained in this previous experience, the one that you just mentioned. The second is that this is another lesson that a lot of funding needs to go and with an accelerated speed and sense of urgency for TB in going forward and having this vaccine finally found out. But also in looking forward for other drugs, other combinations, and as already was said, other ways to diagnose. Okay. Why it's difficult to find for vaccine is probably equally difficult like for HIV or malaria or other diseases. TB is a disease that takes a lot of time, and you have people that are infected, that are moving from being infected to being sick with the disease, and then therefore you need to try and protect this move from infection to disease, and you need to protect as well people and children especially not to be infected at all. So there are different angles to look at it.
Okay,
and
but
TB is not a disease
I'm just going to jump in there because you do have quite a lot of optimism that we are eventually going to find a vaccine, but isn't it true that TB gets a lot less attention than malaria and HIV/AIDS. Paul Jensen, do you share Lucica's optimism when indeed the WHO says that it's facing a funding shortfall of some $3 billion a year as of 2013?
Yeah, it's a tempered optimism, I think. The reason, like Lucica said, there hasn't been a vaccine trial in almost a century. The newest TB drug actually was just approved by the FDA in the United States. It was the first new drug in about 50 years. There was a long period almost of like a dark ages in research and development for new tuberculosis technologies, but within the last 10 years especially, we've seen a bit of a renaissance. There are a dozen new vaccine candidates in the pipeline. We have brand new drugs in the pipeline that could be used for MDR-TB that may come online in the next year or so. And new diagnostics. There was a new diagnostic that was approved and is now being rolled out globally. It came out 2 years ago, a fully automated DNA-based diagnostic test. So we're starting to see new technologies roll out of the pipeline. It's not as fast as we would like, but like you said, there are major funding gaps, and in a period now where countries are facing pretty tough economic situations, these are the sorts of things, tuberculosis, that tend to be politicians and policymakers and the public wants to start to ignore them to focus on other things. And I think what our study shows, and some of the things that Lucica just said, we can't afford to take our eye off the ball. There is no slowing down in the response to these massive epidemics. If we take our eye off the ball, if we slow down, if we start to reduce the amount of resources that we're putting into the response, the germs do continue to evolve and they do continue to make people sick. And the economic costs of putting off a response, especially when we talk about drug resistance, it's much more expensive to treat. As it becomes more resistant, it becomes exponentially more expensive to treat. It's much cheaper to prevent.
Okay, Masoud Dara, it's your organisation, the WHO, that's facing this funding shortfall. Do you see it having a direct impact on the front line and a rise in the number of multi-resistant forms of TB?
Funding actually is linked to the TB control. Absolutely, the funding needs is an essential, Lara. The point is, of course, using the funds in an appropriate manner, using resources in an efficient manner. Unfortunately, still some of the resources in some countries are not used appropriately. The other issue also is that, of course, people who are moving from one country to another, seeking for health care in other countries. That's also another issue, that actually tuberculosis does not know any border. and people obviously will seek for care where they can get it. So that's the one message that we have for all the member states, that actually investing in TB control program and in overall health system in other countries is also good for the public health, global public health. So funding in that sense actually should be used more efficiently and also raised on different angles. Actually, we're very glad that Global Fund also is speeding up its support to key countries.
Well, we've put this subject up for discussion on our Facebook page, and here's what some of you have been saying. Fabio Fiorelli says TB is curable with proper treatment, specific antibiotics, for example, but the misuse of drugs and substandard fake drugs can create antibiotic-resistant germs and make it harder. Susan Ozcan says something has to be done to make good medicine programs available for all poor nations. Kamil Omar says developing countries give fake drugs to TB patients, and there are many reasons for this. The one major reason, he says, is existence of corruption and poor supervision of drug control in those countries. Masoud Darrah, the WHO has also come under a certain amount of criticism for pushing patients to attend supervised treatment programs within the national public health system of their countries. But those systems are often very much beyond the reach of the people, both physically and financially. People are forced to go to the local markets and buy the much cheaper drugs. So has the WHO been putting its resources into the wrong systems?
TB diagnosis and treatment should be free of charge for all the patients around. So that's actually a key message we pass to all the member states, that treatment should be free of charge. So no patient should pay for the treatment, because if, as I mentioned, it's mostly affecting poor, and obviously if they do not finish their treatment because of financial reasons, that's not a good idea. So that's a message we pass, that the treatment should be free of charge for all the patients. Having said that, because of the health systems are not so adapting to the treatment, to the patient's needs, so to say, and then there's a long treatment, and some countries they obligate the patient should be hospitalized for a long time, and this also the reason that some of the patients prefer actually to go and get self-treatment. We also advise all the member states to have a control in terms of antibiotic use. So it should be always on prescription, and also what we highly recommend, the direct observation of treatment, meaning that as someone to help the patient to get throughout the whole course of treatment. It can be a nurse, it can be also a family member who has been trained and educated. It can be member of the same community. So it's extremely important to accompany patient, to let the patient finish the treatment, and what we call the direct observation of treatment to avoid further becoming resistant. In terms of quality of medicines, we also highly promote the pharmaceutical companies to go through a pre-qualification. We have actually a system at World Health Organization which can help the countries to go through these regulations to make sure the quality of medicines is satisfactory.
Okay. Luchika Ditu, do you think these are realistic aims, or how do you think we should be better regulating these drugs which are getting to the people?
You know, it's not easy, because you need to work in parallel in different systems. So obviously one big part is to happen in the countries, or the most important one. So first of all, the decision makers and the governments should realize the importance of pre-qualified medicines. And, you know, we speak now about the TB case, but it's the same, obviously, for any drug that we have in countries. So, you know, we should have regulations in place in ensuring the good quality of drugs entering in the country. And as well, in the particular case of TB, the availability of drugs over the counter, it's an issue that needs to be addressed, because as we speak about here with all these drugs, this has horrible consequences on the individuals, but also if you look at the more over the public health impact, because it's an airborne disease. So that's one aspect aspect of it. I was mentioning earlier in the conversation that one way is like trying to fix the things while we speak. We have a structure in the Stop TB partnership that is ensuring for especially the countries with very limited resources and those that are supported by different donors. We are providing through this structured global drug facility some good quality first-line drugs and second-line drugs and quality assured in a rapid manner for countries to ensure that they have the right quality assured treatment in place.
Okay, so I'm going to have to jump in there, Lucica. Apologies. We have run out of time for our discussion today. Good to hear that there's some hope on the horizon, though. Many thanks for our guests for joining us in Washington, Paul Jensen, in Kiev, Masoud Dara, and in Geneva, Lucica Ditu. And thanks very much to you two for joining us on this edition of Inside Story. You can find this programme and others on our website. That's at aljazeera.com. And there you can also leave your comments. Bye for now.